same cohort of are basal-like when they're profiled, but not all of them. And not all of the basal genotype are completely negative for HER2. And rarely some may even show a little PR. But in the end, it's pretty close to synonymous to say a triple negative is a basal-like. In the luminal Bs is where you'll see ER positive, HER2 positives. And I think other than that, this is a very robust classification. It's withstood many, many attempts to deconfabulate it and re-put it together with different profiling algorithms and different decision trees, and it's held up time and time again. Here's kind of my little schematic that I published about whether some of the phenotypic markers like HER2 and the different cytokeratins and EGFR and P53 and how they fit in to the different genotypes on the Peru classification. Now, he's refined it. There's a new, very important subtype he's calling the Claudin-Low. We'll be looking for Claudin-Low variants, mostly in the basal-like group, as a new category of interest. I mentioned earlier the molecular grading where Christo Sotirio showed that there was only 2 grades of breast cancer when they profiled it molecularly as opposed to the pathologist-based Bloom-Richardson grading. We'll skip through that one, and I've already gone through this data for you. Now we can talk about Oncotype and MammaPrint. I mean, clearly Oncotype is a very, very, very dynamic story with information in it that's of great, great lessons in a variety of ways. I think firstly, the strategy to combine the development of the test with a relationship with a major national clinical trials group, the NSABP, was great wisdom. It gained access to great scientists, access to great clinicians, and access to great tissue blocks, which were critical for the discovery of the 21 gene that weighed up the recurrence score assay, as well as its validation on subsequent trials and the ability to get therapy-specific outcome data, first to tamoxifen, later to CMF chemotherapy, and even to get a placebo group that they had to show it was a standalone prognostic factor. I think also the strategy that they took, which was to, instead of seek FDA approval or clearance at the 510K level, they would get a CLIA-approved license in the state of California and offer the test as a central laboratory test. Mail us the specimen, we'll mail you the results. And there were a few stumbles when the test was originally released because without looking at what went in to the tube before the mRNA was extracted, there was risk of getting aberrant results. And the main problem they ran into in the first year or two was that people would send them blocks that had both the invasive cancer in it, but also areas that had been previously biopsied. And what you'd see is that a patient expected to have a low recurrence score would come out with a very high one, and it made no sense. The reason being wound healing in the previous biopsy would bring a lot of Ki-67 message into the Oncotype test result, falsely elevating the recurrence score. The response to that was simple: hire pathologists. So they hired some pathologists who look at the tissue that's going to be used to make up the test before they extract the mRNA from it to make sure it's not contaminated with biopsy, wound healing, and that type of false proliferation that's not characteristic of the tumor itself. After that, I think we've seen nothing but success for the test. It was launched based on a compendium of publications in peer-reviewed, prestigious journals like the New England Journal of Medicine with multiple validations. It saw a big head-to-head comparison by Peter Ravden with Adjuvant Online, where Oncotype outperformed. Now, if you go, I think as the oncologists do, to Adjuvant Online, there's a nice box where you can put in the recurrence score, and you get a more robust predictor of risk of relapse than you would get if you just had the clinical pathologic variables of Adjuvant. Then, more recently still, was the data that the test was performing better after release than it did in its clinical trial. In its clinical trial, it had a 7% error rate. If you had a low recurrence score below 18, you still had a 7% chance on tamoxifen alone the tumor would relapse, which I thought was fairly high. I thought we were doing better than that before we had Oncotype and just using the parameters we had: grade, proliferation, Ki-67, IHC, HER2. But now, after 50,000 tests have been done, The new data is showing a relapse rate for low risk of slightly under 3%. So that's pretty impressive that it actually performed better after it was released in the field than it did in a controlled clinical trial. One of the big obstacles, of course, was reimbursement. This is a test that lists $3,600 cost. Were third-party payers going to pay $3,600 for a diagnostic test, especially after there were so many existing tests for breast cancer? At first, there was resistance, but third-party payers began to realize that if a woman with lymph node negative ER-positive breast cancer, and HER2-positive patients were not being sent for the most part, some were, but not most, got a low recurrence score, there was a good chance that the patient in consultation with her oncologist was going to decide not to take cytotoxic adjuvant therapy, and that in aggregate, the third-party payer was likely to make up far more than the cost of the $3,600 for the test with the savings from not having to pay for the chemo. And it became then popular among third-party payers, get adjuvant, get the Oncotype DX test. To my knowledge, the payers aren't saying we won't pay for chemotherapy if you still want it and your recurrence score is below 18. But I wonder if there won't be a pretty aggressive one someday who'll do something like that. So the main point is the way the test is being used as a method of personalizing breast cancer care that mostly ends up in the holding back of the use of more expensive treatment not likely to work. It makes sense to the healthcare system as a whole, hence it's growing pretty rapidly. Is it the best test to do this? Well, we don't know. It has competition. And it has what we might call risk, and that risk is TAILOR-X. Let's go into TAILOR-X. I think you know all this data. A couple of things for those who aren't really familiar with it. It's driven predominantly by two genes, Ki67 and ER. When ER is very high and Ki67 is very low, the recurrence score is very low. When Ki67 is very high and ER is very low, the recurrence score is very high. The other reporter genes, of which there are 13, there's 2 and then 13 others. The other genes are all, 14 others, the other 5 are all just housekeeping reference genes for deciding the relative mRNA levels. Come into play when Ki67 is not all that high or low and ER is not all that high or low. Then you look at the others to try to get in and around the cutoff. The intermediate risk is considered by some investigators to be pretty uninformative. The patient can just go either way, and that the test is at best at the two opposites, the high risk and the low risk. On occasion, a patient thought to have very low risk disease gets a high recurrence score, and the therapy plan is completely revised based on the test.